Department of Internal Medicine, Faculty of Medicine, University Malaya, Kuala Lumpur. He's also the head of the Diabetes Unit of University Malaya Medical Center. And this is the expert that we have invited today. And this is the Meet the Expert session. And the topic is bone health for women after breast cancer. The main idea is for Dr. Luqman, who would explain to us about some of the very basics of bone health for women after breast cancer. Over to you, Dr. Luqman. Welcome to the session.
Thanks, Ranjit. So I prepared a very short overview on the bone health, but after this we can take Q&As and we can talk in a bit more detail. Why I prepared this overview or this briefing is because we just want to cover some basic things so that when we take the question and answer later, I hope everyone can speak in the same language and people can understand what we are talking about when we take the questions and answers. Yeah. I will talk about bone physiology, about the effects of menopause on bone, effect of breast cancer and effect of cancer treatment on bone as well. Why is it important to diagnose and treat osteoporosis? How osteoporosis is diagnosed? And how do we treat osteoporosis? Mainly by lifestyle intervention and also by medical treatment. Yeah. So first and foremost, I want to introduce this important concept that the human bone is actually a living tissue. Yeah. The bone is not just a tissue that is made of calcified or calcium, but it is a tissue that is made of cells. There are cells called osteoclasts. These cells actually they absorb bones, and there are cells called osteoblasts which push in new bones. Yeah. Why is this important? Think about it this way, because throughout our lifetime, our bone will undergo the stress of our weight. So imagine like at the soles of your shoes, right? After you walk after 1 year or 2 years, then the soles we get damaged and we get worn out. But unlike our bone, unlike that, our bone actually it regenerates, it replenishes, it repairs itself. So that's why we keep on having healthy bones throughout our 5 decades, 6 decades, 7 decades of life. And this is just a basic diagram. I know the diagram might look complicated, but don't worry about all these terminologies. I just want to introduce the concept that although the bone looks like a stiff rod of calcium, microscopically there are these cells that regulate the bone physiology. When we talk about bone physiology, we will talk a lot about bone turnover. Yeah, this concept is bone turnover is important in osteoporosis because osteoporosis is, by the fundamental of it, is a defect, is a disease that's characterized by a defect in the bone turnover. Yeah. So how this bone turnover works? It basically, although this image is a bit misleading because it looks like the process happens on the surface of the bone. It's actually is not. It happens throughout the entire bone volume. Okay. What happens is that in order for you to build new bones, right? In order for our body to build new bones, you first have to remove the old bones first. Because otherwise, if you just continue to build new bones, you will end up with a thick and heavy bone which might not be better anyway. So what we need is a fresh and a pristine and a strong and a pliable bone. So in order to do that, the body will remove the old bone first. This process of removing the old bone will trigger a series of process that lays down new bone minerals, or we call it bone minerals. Yeah. So this, when these osteoclasts absorb the old bones, right? These osteoblasts will lay down new bones, and eventually this surface will be covered all with new calcified bone. So this process happens slowly but continuously throughout the whole skeleton, and this happens at different parts of the bone. Let's say maybe like at one point this particular spot is undergoing turnover, and then at another day and a different spot will be undergoing turnover. But these spots are like microscopic spots now, so it's not like macam you suddenly get your bone disappear, but it's not. It's more like a microscopic spot that it absorbs a small microscopic amount of the bone and it lays down a small microscopic amount of new bone. But because this process happens throughout, so eventually after some time you will get a completely fresh new bone even as an adult. Yeah. Okay. So this process of bone turnover, we call it bone turnover, is basically a process of bone resorption and then followed by a new bone formation or new bone deposition. And this process is regulated by age, by the availability of calcium, by the availability of vitamin D, and also very importantly by the effect of the hormones. And among the most important hormone is the estrogen. Yeah. And when we talk about menopause, we are basically referring to a state where the body of the women, they stop producing estrogen. So at that stage, what estrogen does before menopause is that estrogen balances this bone turnover. It balances the effect of osteoclast and osteoblast. Remember that this concept that if you want to get a fresh bone, you don't want to get too much bone resorption, you don't want to get too much bone deposition, but you want to get a balance between bone resorption and bone deposition for you to maintain a healthy bone. In a postmenopausal osteoporosis or after menopause, the lack of estrogen or the estrogen deficiency causes an increase in the activity of osteoclasts. So it means that there are more bone resorption, and this is accompanied by a decrease in the bone deposition. But the main effect is really an increase in bone absorption. So when we look at what we call as a bone turnover marker, these are some chemicals that can reflect how much bone is being replaced throughout at a certain point in time. So when you look at bone turnover marker, you will find that in people who had underwent menopause, their bone turnover marker is higher. So it means that they had higher bone turnover, and this process of higher bone turnover is because of an increase in the activity of osteoclasts or this bone resorbing or bone absorbing cells. So as I will explain later, most of our osteoporosis treatment is basically treating this target cell. So we are basically treating this osteoclast so that it will prevent it from absorbing too much bone, but this will also carry some benefit and implication which we will talk about later. Yeah. In terms of cancer itself, so how does cancer affect our bone? Basically, it does in a lot of ways, in multiple different ways. Among things as we mentioned earlier, things that will ensure a good healthy bone would be the availability of calcium, the availability of vitamin D, your diet. So in people who underwent cancer treatment, depending on the stage of cancer or depending on whether they underwent chemotherapy or not, many of them had poor nutrition. And in the stage of cancer treatment, many patients, they also underwent what we call as a catabolic state. A catabolic state is a stage where the body breaks down proteins and glucose in order to provide more energy for a person who is not well or who is sick. So for example, like if I get fever or if I get an infection, for example, then my body will be sick and I will need more energy from this protein and glucose. So that's how the body provides more energy for me to fight off the illness. The same thing happen also in people with cancer. So this explains why a lot of people with cancer, they actually they experience weight loss as well because of this catabolism. Yeah. Some cancer treatment can cause bone loss, mainly in the treatment like chemotherapy, the usual chemotherapy, but more specific for breast cancer would be a group of drug called the aromatase inhibitors. Yep. This aromatase inhibitor is typically used for people with receptor positive breast cancer. What it does is that this aromatase enzyme is an enzyme that regulates the production of estrogen in the body. And when we give a drug that inhibits aromatase enzyme, so what will happen is that the body will develop a state of estrogen deficiency, and this will prevent the cancer from growing. But as a side effect, of course, this causes accelerated bone loss because of the estrogen deficiency. And this is the same concept that happens when during menopause also, estrogen deficiency or menopause. So this actually increases the bone resorption by osteoclast. In some cases, especially for those with more advanced cancer, those with disseminated cancer or those with spread to other parts, right? Some cancers, they might produce hormones. One of the commonly encountered hormone is what we call as a PTHRP, or parathyroid hormone related peptide. This hormone actually will cause the calcium in the bone to be taken up and to be mobilized in the blood. So what happens is that you get a bone which is lacking in calcium, and this contributes to the accelerated bone loss as well. And some other hormones like the COX-2 and also the IL-11, these are all inflammatory hormones. So this produces a state of pro-inflammatory or a state of increased inflammation in the body, and this will further lead back to the state of the catabolic state that we mentioned earlier on. Yeah. And last but not least, in some people, they have cancer that goes directly to their bone, that deposits on their bone and grows on their bone. And this cancer causes hormonal effect on the bone, on the adjacent bone, and plus it also causes a local effect by invading and by destroying the adjacent bone. Yeah. So of course, these things require different treatment. For today's talk, we will focus mainly on osteoporosis treatment, but in the Q&A, I'm more than happy to take questions about how do we treat bone metastasis, how we treat hormones related from the tumor. So we can discuss all that in the Q&A. Okay. Why is this issue important? Why do we talk about bone? I mean, after we have fought cancer, after we talk about other problems, why do we suddenly want to focus about bone? Because it causes death and disability. This is a study that look at what happens to people who had hip fracture after 1 year. So about 20% of them will die. About 20 to 30% of them will end up in a nursing home, because this graph is not complete. In the actual paper, about 21% die within 1 year, 27% ended up in a nursing home. So in a way that what we are trying to say is that if you had a fracture, right, within 1 year, about half of people who had a hip fracture will not be at their home because they either die or because they end up in a nursing home. And the reason why they end up in a nursing home because of this permanent disability, almost half of them cannot walk after a fracture. 80% of them, the vast majority of them, will be unable to perform at least one normal activity that they used to do before. So this is why we feel that identifying, diagnosing, treating osteoporosis and preventing fracture is one of a major public health priority that we need to address. Yeah. The next part is how do we diagnose this osteoporosis? Basically, in short, we diagnose with a test called the DEXA scan. But as an overall assessment, we look at your symptom, whether the patient has back pain, whether they have a loss of height over time, whether they have abnormal posture, and then we assess about all the other risk factors that could have caused osteoporosis. Post-menopause, smoking, alcohol, people with a family history of osteoporosis, people who are sedentary, people who are thin, people with vitamin D and calcium deficiency, people who are of older age, people who take certain drugs, what we call as steroid drugs, or like prednisolone, for example, or any certain treatment for seizure or for epilepsy, and medical conditions that weaken calcium absorption, or medical conditions that can cause osteoporosis. And of course, this includes malignancy and cancers as well. Yep. So how do we diagnose? Is either by doing a DEXA scan, which I will show in the next slide, or if you have a fracture like this. So it means either if you have a fracture, then we diagnose osteoporosis, or if the patient does not have a fracture, then we arrange a DEXA scan. And if the DEXA scan will tell us the T-score, and the T-score corresponds to a state of osteoporosis, then we diagnose this patient as osteoporosis. So how we do a DEXA scan? This is a typical example of how a DEXA scan looks like. So you will have a machine. You will have this what we call like an X-ray beam. Yeah, it is basically an X-ray machine, but it carries a lower radiation than X-ray. That's why the image looks a bit more grainy than X-ray. It's a bit less is quite a lower resolution than the normal X-ray, but because that's the point is that it doesn't need to look at the anatomy, it just want to look at the density. So what happens is that there's a beam of radiation that goes to the spine, and also this technician will also redo the same test, and they also do a beam of radiation that look at the hip. So most BMD will report the spine and the hip like this, and then most depending on the model, depending on the manufacturer model, they will give a diagram like this that shows a normal bone, osteopenia or osteoporosis bone. Osteopenia is a state in between normal bone and osteoporosis bone, and they give this for both spine and also hip. If you look at the end here, right, there's a number called the T score. Yeah, there's a index called the T score. This is what we look at when we diagnose osteoporosis, usually in people after menopause. So if, let's say, the T score is less than -2.5, if it's lower than -2.5, yep, it means that the patient has osteoporosis. So this happens regardless of age. These three lines here, these three lines on the BMD here, shows where a normal person's should be at a different stage of their life. So at a different age, for example, like most people from 20, 30, 40, 50 years old, they should be in the green zone. But by the time they go into 60-year-old, they start to enter the yellow zone. By the time they're 70, 80 years old, they will be deep into the yellow zone, and some people will be in the red zone as well. So these are the people that we will treat. So if you look at this, like most of our patients are actually in the age of between 70 and 80 years old. Okay, so I'm quite coming to my end here, but after this we can open up to Q&As. Basically, how do we treat osteoporosis? So now we know how to diagnose, but how do we treat osteoporosis? There are two components of treatment: lifestyle intervention and medication. But I would summarize the entire treatment of osteoporosis in 2 words, which is fracture prevention. Because this is what we really want. When we treat osteoporosis, we want to prevent fracture. Yeah. How do people get fracture then? Of course, they get fracture because their bones are brittle, because they have osteoporosis. But there are also other things that contribute to fracture. For example, if they have arthritis, if they are not stable when they walk, if they tend to fall down, if they have poor vision, if they have imbalance, if they have a previous stroke, for example, if the house is not accommodative for old people to walk inside the house. So these are the things that can predispose a person to fractures. So in essence, the treatment of osteoporosis is directed towards this end goal, which is fracture prevention. Some of the treatment, if you can see, of course, look at bone strengthening measures, because bone strengthening is a major component of fracture prevention, but it is not the only thing that we can do about fracture prevention. There are other things that you can do in order to prevent fracture. For example, smoking, calcium deficiency, vitamin deficiency all causes weak bone or brittle bone. So therefore, we recommend patients to stop smoking. We recommend them to take adequate intake of calcium from dairy products or from vegetables. Some people who don't take a lot, they may receive calcium supplement as well. We also recommend people to take vitamin D supplements, because we found that most of our patients do have vitamin D deficiency. And people with osteoporosis, they need even more vitamin D than people without osteoporosis. So most people that we treat so far, they do require vitamin D supplements to a certain extent. Yeah. Apart from strengthening bones, of course, there are, like I said, there are other ways of preventing fracture mainly you can also strengthen your muscles. Yeah, you can do exercise, you can do muscle strengthening. Reason why muscle strengthening is just as important, because when you walk, when we balance ourselves, when we stand up, we don't just put our weight on the bone, but we also put our weight on the muscles as well. And when you have a strong bone plus a strong muscles, then this will contribute together to promote a better balance and prevent people from falling. Yeah. And as for people who have recurrent falls, they might want to talk to a fall expert. And these are usually geriatricians who will specialize in fall prevention. There are many reasons why people fell down. It could be because of a heart problem, it could be because of a stroke, it could be because of a nerve problem, it could be because numbness on their feet, it could be because of diabetes, it could be because of some medication, it could be because they are too sedated, because of painkiller, because antihistamine. So this is what a good geriatric will be able to do. A good geriatrician will be able to do. They will look at why do people fall down, and usually in these cases there are multiple reasons why people fall, and they will try to intervene and try to modify the risk factors for fall. And also what they will also do is that they will advise patient, they will train patient on how to walk about without falling, or how to walk about, how to move about, and at the same time lower their risk of falls. For example, like how to get off from bed, how to get off from chair, how to walk in the house, how to get off in the car, get in and out of the car, and things like that. Yeah. This will be my last slide. Because these things are quite patient specific. So it's not like macam all this treatment can be used for all patients. Yeah. So for example, a common treatment for osteoporosis that gynecologists would use would be estrogen or hormone replacement after menopause. But this is obviously not suitable for people with breast cancer, because those with cancer receptor positive, they might get cancer growth from estrogen or hormone replacement. So alternatively, you can use what we call as a selective estrogen receptor modulators. So these selective estrogen receptor modulators, some of you might be familiar with tamoxifen, because this is used a lot in people with breast cancer. We use raloxifene for people with osteoporosis. Why it is selective, why we call it selective estrogen receptor modulator, this is because they act on the estrogen receptor on the bone, right? So they give all the benefits of estrogen on the bone, but it does not act on the estrogen receptor on the breast or on the breast cancer itself. So in some studies, they have shown that patients who take raloxifene, for example, or on top of the benefit that they get from their bone, they also get a lower risk for invasive breast cancer as well. And we all know that tamoxifen is widely used as a hormone therapy in people with breast cancer as well. Yeah. Probably the most common drug that we use in our practice is alendronate. Yeah, this is an oral bisphosphonate. Okay, bisphosphonate is the most common drug used for osteoporosis. Reason because it is a very highly versatile drug. Yeah. For example, like estrogen or raloxifene, for example, they have a certain limitation. They can only be used for people with spine osteoporosis. They can only be used in the early age of osteoporosis. In the late age, some people, they might get higher risk of stroke. So, but whereas bisphosphonate is probably the most versatile drug that we can use, and we can use for almost all forms of osteoporosis, including postmenopausal, including people who get osteoporosis because of medications or because of medical illness. It comes in two forms, either oral, tablet, or injection. The most common that we use is oral for obvious reason, so that patient don't have to inject. But some people do receive injection as well. The thing about bisphosphonate is that it is very effective. It works very well, but at the same time, requires a very meticulous. It requires a very meticulous way to make sure you take it properly. Because if you don't take it properly, you might not get the benefit of the drug. And the reason, because bisphosphonate tends to bind to food. Yeah. So and it can bind to like calcium tablets, food, even some people say even in mineral water also it binds to the minerals or binds to the metals inside the mineral water itself. So because most of our patients, they are on other medication as well, they are also on calcium supplement, they are also on, for example, some of them take iron as well. So these are the things that you have to meticulously arrange so that this medication don't interfere with their bisphosphonate treatment. One way to avoid this drug or this food interference is obviously by giving injection of bisphosphonate. So injection will bypass all this food interaction, food binding, binding to calcium supplement, binding to iron supplement. And we can do that by giving a once a year injection of zoledronic acid. Yeah, this is also what we call as Aclastar. Um, this drug in general is very good. In fact, it has to a certain extent better effect than alendronate. It is also a very, very versatile drug. And because it's just a once a year injection, some patients, they actually prefer to get this rather than take medication like every week, for example. So they just come once a year to get the injection. But the limitation is that in some centers that don't have a daycare facility to inject this zoledronic acid, this might not be technically that feasible. For example, if you go to a GP and your general practitioner might not have a setting where they can give zoledronic acid infusion for 1 hour infusion, for example, this might not be a very practical option for them. But I think some people might also have heard that we also use zoledronate for cancer treatment, especially those with bone involvement. This was before we have a newer drug called denosumab. Yeah, denosumab works like a bisphosphonate. It has the same versatility as a bisphosphonate, but it works in some way even better than bisphosphonate. And instead of giving injection, denosumab is given under the skin. So this is given like how we will inject insulin, or how you would give vaccination, for example. So this denosumab is given typically on a twice yearly injection, but in some people with bone involvement from their cancer, they might require more frequent denosumab injection. Okay. All these drugs, bisphosphonate and denosumab, what they do is, like mentioned earlier, what they do is they prevent osteoclast from resorbing the bone, from eating up, from causing too much bone resorption. But remember that when we talk about the bone turnover process earlier on, the bone turnover is basically a coupling process or a balance between bone resorption and bone formation, and you need both to get bone turnover. So what happens when you stop this osteoclast from uh, bone resorption, right? This bone turnover process gets stunted. So, and when it gets stunted, in some cases, we do notice that after a certain years of treatment, people who are on bisphosphonate or on denosumab, they do get a certain typical, or they do get a certain uncommon type of fracture. We call it as an atypical femoral fracture. And this typically happens after about 5 years or more of treatment. We can talk a bit more about this atypical fracture in a while during Q&A. But in the gist of it, when we talk about atypical fracture, as a clinician or as a doctor who treats osteoporosis, what we decide is basically we decide based on the patient's risk of developing an osteoporosis fracture versus the risk of developing an atypical fracture. And in most people, the risk of getting an osteoporosis fracture is much higher than the risk of getting atypical fracture. So in some people, we continue treatment for 5 years. But in some other people where the bone remains brittle after 5 years of treatment, then we may extend their treatment up to 10 years. Yeah. The last drug that we use, the one that is available in Malaysia, is called teriparatide. This is not commonly used in people with osteoporosis, namely because of the cost. This drug alone causes like 21,000 ringgit for the entire cost of treatment, and this entire cost of treatment is mainly just for about 12 to 18 months only. So we don't usually use teriparatide unless the patient had very severe osteoporosis with multiple fracture, and therefore we may combine teriparatide with all the other above treatment. But at the current stage, the most common treatment that we use are this bisphosphonate or denosumab. Some people, they may use selective estrogen receptor modulators depending if they are young age, if they don't have a hip osteoporosis, then they might be a good candidate. Yep. So that's about all, at least for the initial briefing. Now I'm quite happy to take questions.
Thank you, Dr. Luqman. I think that was very clear. And we will now move on to questions with 74 years of age. She had breast cancer in 2001, had surgery, chemotherapy, radiotherapy, and hormone therapy. She's saying, is my knee deterioration connected to my cancer?
Is your what? Knee?
Knee deterioration, is it connected to my cancer?
Knee, as you mean the knee joint?
Yeah.
Okay.
I think it's to do with whether she's thinking that it is osteoporosis.
Okay. Let me just clarify that. When we talk about osteoporosis, this tends to be confused with osteoarthritis, and these are two very different conditions. Yeah. Osteoporosis is a condition that predisposes your risk of fracture because of the poor bone strength, or because of the weak bone, or sometimes because of the brittle bone. Whereas osteoarthritis is a different process. It's a process where you get too much wear out signs, or where the bone wears out. For example, like if let's say you in between the bones, let me just show you a diagram. This might help. In between joints, right, there's a structure called the cartilage that protects bone from rubbing from each other. Yeah, so this cartilage is like a smooth surface that facilitates joint movement. What happens in osteoarthritis is that this cartilage gets worn out. So when the cartilage gets worn out, then the bone surface gets exposed. And when the bone surface gets exposed, it becomes painful when it rubs against each other. And of course, over time, when it continues to rub against each other, then this bone will eventually get damaged as well. And some people might require joint replacement because of that. But this is a very different entity from osteoporosis, which is basically the topic of our discussion today. So I hope that helps to explain the answer.
Okay.
Does cancer causes osteoporosis, or does cancer affect osteoporosis in any way? Answer is no. Not that we know of.
Thank you, Dr. Luqman. Next question. She's 52 years of age, had breast cancer in 2017, had surgery, chemotherapy, and radiotherapy. She says that she uses the word poking. I think it's piercing pain in the heel of her foot. Is this due to the calcium reduction in her body?
Most of the time it's not. It could be a spur. This can happen at the bone of the foot. It can pull out this attachment part of the bone that causes pain. But actually, a more common cause of foot pain is what we call as a plantar fasciitis. Yeah. So what happened is that in these people, right, they get inflammation at the ligaments, or at the fascia that covers the sole of the foot. This plantar fasciitis is a self-limiting problem. So it means it's a problem that goes away after about a few weeks of treatment, usually. If it doesn't go away after about a few weeks, then this might need further tests and you might want to do an x-ray just to check. Is it because of low calcium? It is not because of low calcium. Like I said, it could be a spur or it could be a fasciitis, which is most likely which is the more likely cause in most people.
Okay, we have another question. She's 54 years of age, had breast cancer in 2012, and according to the doctor, she has insufficient calcium intake.
Yeah.
Now she's on an injection annually.
Yes, what?
She did not mention the name of the injection, but she says, what will be the impact if I do not take the annual injection?
Annual injection.
Yes,
She's on an annual injection.
yes.
I might be making a wrong assumption here, but I think that annual injection is zoledronic acid. Okay.
Okay.
I think that injection is zoledronic acid. Is there any effect if you do not take annual zoledronic acid? We use zoledronic acid to treat osteoporosis. Yeah. So, I mean, obviously the answer is quite obvious. If you don't get the injection, then your osteoporosis will not get its treatment. But the good news is, zoledronic acid can last in the body for quite a few years. Yeah. So, for example, if let's say you miss your injection because of the MCO, because you reschedule your appointment, this is perfectly fine because the zoledronic acid will continue to remain in the body, but not for denosumab, which needs to be injected on time for every dose. Yeah. What happens if she doesn't take enough calcium? Yeah. In most of osteoporosis treatment trials, they make sure that patients receive adequate amount of calcium and vitamin D to get the most benefit of the osteoporosis drug treatment. What happens if a person gets osteoporosis treatment but do not take enough calcium or vitamin D? There might be a possibility that they will not get the best benefit out of the drug. Yeah. They won't get any benefit at all? Probably they will get some benefit, but they won't get the full benefit of it.
Okay, I hope that is useful. And we go to the next one. What type of exercise is best to prevent bone loss after menopause? And do weight bearing exercises help mitigate osteoporosis?
Okay. The type of exercise that we recommend would be weight bearing, namely walking or running. Yeah. Reason why weight bearing is because we also want to train the muscle and the bone. But to be honest, if you ask me, any form of exercise is fine. Any form, if you like Tai Chi, if you like dancing, any form of exercise is fine actually. Some people might like swimming. Some people might argue that swimming is not really considered a weight-bearing exercise. Some people say cycling might not consider a weight-bearing exercise. But in reality, if you ask me, any form of exercise is fine. Exercise carries much more benefit than just building up or strengthening your bone and your muscle. It also improves your mood. It improves your networks, because a lot of people, when they get cancer or when they get treated for cancer, right, they get isolated, they lose contact with their friends. So these are ways on how they might want to reach out, they might want to get connected, they might want to make friends and go out together. And there's a lot more benefit to this than just bone and muscle strengthening lah. But in general, I usually we recommend weight bearing, but I wouldn't make it such a strict recommendation lah. An important benefit of exercise that is often understated as well is that exercise improves a person's agility, and this is important for old people. Old people, many of them has poor agility, and this predisposes them to falls. So for example, like if you trip on something, or if you trip on a carpet or on a toy on the floor, for example, or on a wet floor, for example, right? Most people with enough agility, they will be able to balance themselves and readjust their steps so that they don't fall down. But in some old people, because of their poor agility, they end up with a fall because of a simple trip. And this is how exercise really quite be helpful, because they improve agility in old people, and this helps them to prevent falls as well.
Okay, I think in many ways it is also body balance, coordination,
Yep.
and also sometimes as they get older, we get older, our balance on left and right can also be affected quite a bit because of our habits of sitting, standing, walking, and doing different activities as well. I guess there's so much more to just just the fact that doctors tell us to do exercises, but there is so much more benefit than just strengthening the bone, because it's muscle strengthening, it's coordination, it's balance, it's a lot of other things, right, doctor?
Yeah. Doctor, which type of estrogen causes bone density decrease?
We have two
I'll
questions.
probably say it's not lah. It's
But
just that
you can answer this one, which type of hormone. But we have two more questions that I will read out to you afterwards.
I just go through this quickly first.
Yes.
Yeah. Okay. Should I wait until I'm diagnosed with osteoporosis to do treatment, or should I do preventative by taking Prolia jab every 6 months? Now, my answer is you need to wait. You need to wait for you to get to develop osteoporosis. Then your doctor will start you on treatment. Reason because the trials were done on people with osteoporosis, so we cannot assume that people without osteoporosis will get the similar benefit from what the trial shows. Yeah. But in the meantime, if you don't have osteoporosis, you can always take vitamin D supplement and also take adequate calcium from your diet. Apparently, there is a research showing benefit of Prolia in breast cancer. I'm not aware of this unless there's a bone involvement, in which case there is a benefit of denosumab. Can we take any calcium pill or Prolia jab while on tamoxifen? The answer, if you are on tamoxifen and your bone is very osteoporotic, I would probably say yes, we can consider that. Okay. Is there any possibility to reverse osteoporosis? We are not there yet. Our technology is not there yet, so I can't be that optimistic. But we certainly can treat, and we certainly can reduce the risk of fracture. I have bone metastasis with degenerative changes seen in 2012 and was given calcium carbonate and calcitriol tablet daily with Zometa every 3 months. Can I ask why calcium tablet and calcitriol is important? Okay, calcitriol is a form of vitamin D. Calcitriol or vitamin D helps the person to absorb calcium that they take by mouth, either from by food or by calcium supplement. Yeah. The reason why adequate calcium and vitamin D intake is important is so that your bone get enough minerals to build a healthy bone. And this is what I suspect your doctor is trying to do. So your doctor is trying to treat the bone process and at the same time try to make sure that you are taking adequate calcium and calcitriol. But I would probably say that this combination carries some risk of high calcium in the blood, so you might want to check regularly with your doctor what's your calcium level, just to make sure that we are not taking too much calcium. Yeah. Okay. What dosage of calcium is suitable for prevention? When I supplemented, my blood test showed above range, so I stopped taking. Is too much calcium a sign of metastasis too? What other markers to look at? If your calcium from your blood test is above normal range, talk to your doctor. This is not because of too much calcium intake. If your blood calcium is higher than normal, this could be because of a bone involvement. Talk to the doctor. This is not because of calcium intake. So I would probably say that this, the question whether you should stop taking, maybe you stop take and then talk to your doctor first lah. Yeah. Okay. I'm a breast cancer patient since 2019. Now taking tamoxifen. I'm having lower back pain. This happened to my right side around my hip area. Is this osteoporosis effect? Possibly, but we won't know unless we get more information. We need to know your age, your weight, your BMI, and also you might want to do further tests like the DEXA scan just to see whether you have osteoporosis or not. Yeah. What is the vitamin D dose that we should take daily? In general, about 800 to 1,000 units. Some people might require more. but about 800 is probably the minimum that people with osteoporosis require. People without osteoporosis, they may require slightly less, between 400 to 600. But people with osteoporosis, they certainly require 800 or more. Yeah. Okay, 59 diagnosed in 2018, surgery done, radiotherapy done, estrogen balance. What happened when one is hormone therapy, Arimidex or Arimed to prevent estrogen? Okay, what happened when a person takes estrogen inhibitors? What happened is that they will get estrogen deficiency and they will get accelerated bone loss. Was formerly on calcium supplement, now replaced by colostrum, which has one gram of calcium. I think should be fine. DEXA scan for bone test on hips area. Is there a scanner that take bone test for the whole body? There is, but it's not necessary. Usually we diagnose osteoporosis, mainly we look at the spine and the hip. You can do a full body BMD, but it's not generally necessary. Instead of taking vitamin D, going into the sun or 3 times a week, not enough. Yes, it is not enough. Usually most people will need to take some supplements now. Zometa, half yearly after radiotherapy in December 18. This year, take a Zometa for 1 year since 2nd June. Is it alright to take another half yearly Zometa coming 2nd December? I would probably say talk to your doctor. This is not the normal dose that they use for osteoporosis, but I suspect the doctor might have their reason to give half yearly rather than yearly dosing. Yeah. From S4Zen again, what actually causes bone metastasis? Is it because loss of bone density? Long story lah actually. This is a long discussion. Some cancer cells have certain affinity to certain tissue. Yeah, not all cancer can go to all tissue. For example, like you hardly see any cancer that goes to the skin, right? Like you hardly see any cancer that spread to the skin, but some spread to the liver, some spread to the lung, some spread to the bone. So the reason is because of the microscopic architecture or the environment in the tissue that makes cancer cell goes there. Yeah. I have pain along the thumb to the wrist joint. Is it due to chemotherapy? What would be your recommended action? Again, talk to your doctor. It is most likely not because of chemotherapy. It is not because of osteoporosis either. Some people, they do get hand and wrist pain because of arthritis, because of inflammation. But again, talk to your doctor. They will be able to assess. I have been treated with denosumab for 3 years. Can I continue to have this injection? Yes, you can continue denosumab for up to 10 years. But how long you should take denosumab depends on what's your BMD. Yeah, your doctor might stop denosumab earlier if your BMD goes to normal. So it depends on the BMD, but as a general rule, you can take denosumab for up to 10 years. Can a breast cancer patient drink milk to avoid any bone problem? No problem, you can drink milk. Yep. Is it true that standing under the sun from 8 to 10 can replace taking vitamin D? No, not true. It's not enough. You still need to take vitamin D supplement. Breast cancer survivor for 13 years, has been on tamoxifen for 5 years, then 3 years, done a DEXA scan, told that you have osteoporosis on Fosamax. By the way, Fosamax is alendronate. Yeah, I didn't mention earlier on. It's a tablet oral alendronate. I was on Fosamax for about 3 years, but now was advised to see an endocrine doctor next week. Why was the need to see the endocrine doctor? I stopped my Fosamax for 3 years already and now only taking Caltrate. I cannot answer this question because I do not know what's the context here. Probably there is some reason why your doctor is referring to endocrine, but I cannot specifically tell you why the doctor write the referral. I can only tell you once I see the referral letter. But I cannot take this question on this platform. Okay. I am 59 years old, breast cancer in 2019, had chemo, radio, and treatment on anastrozole. Anastrozole is a form of aromatase inhibitor. Yeah. Just received 1 year of Prolia jab. Currently, I'm not taking any supplement. Should I start taking now? Yes, you should. I had breast cancer in 16 and 59 years old, had surgery, chemo, and radio, 6 cycle of Zometa infusion for first 3 years until mid-19. Due for bone scan, and I'm taking supplement of 400 milligram calcium. Okay, I assume it's calcium. Is 400 milligram calcium sufficient? I go under the sun in the morning. How much calcium is sufficient depends on your calcium level and depends on how much you are taking by food. If let's say you already take adequate amount of calcium in the food, if you take a lot of milk, if you take a lot of vegetable, 400 milligram might just be sufficient. If you don't take enough calcium, or if you don't take enough meat, if you don't take enough vegetable in your diet, then 400 milligram is probably not enough. So is 400 milligram calcium sufficient? I would take a more detailed diet history to know what do you eat on a regular basis. Then only I will decide whether 400 milligram of calcium is sufficient or not. I do go under the sun in the morning. How long do I be in the sun to get sufficient vitamin D? This is almost certainly not sufficient. Yeah, I don't think any amount of going under the sun will be able to give 800 or 1,002 units of vitamin D every day. So I wouldn't recommend this. Yeah. How do we differentiate between urinary tract infection and osteoporosis back pain? By the way, I'm taking letrozole for 9 months. Letrozole is also another form of aromatase inhibitor. How do we differentiate between urinary tract infection, back pain, and osteoporosis back pain? Usually, urinary tract infection do not cause back pain. They cause pain when you pass urine. They cause lower abdominal pain. Severe urinary tract infection that goes to the kidney can cause back pain, but this will obviously happen in severe cases. And in which case you will know, like you will get fever, you will feel very unwell, and this will be very obvious. Yeah. So I would probably say this back pain might be because of a muscle or spine problem. The only way to know is to do an X-ray and get examined. How much vitamin D supplement to take? Between 800 or more, at least 800. Should one go for vitamin D blood test? Yes, good question. Should you go for vitamin D blood test? The answer is yes. This is highly recommended because the level of vitamin D determines how much vitamin D you need to take. Yeah, for people with low vitamin D or vitamin D deficiency, they will need more vitamin D supplement as compared to people with enough vitamin D. I have recurrence to bone after 4 years. After the therapy, I received denosumab monthly and now every 2 months. Should I take calcium supplement at the same time? No, unless advised by your doctor. Because in some people with bone metastasis, they might already have high calcium in their blood. So because of that, some doctor may not recommend taking calcium supplement at the same time. So you need to talk to your doctor and need to check what's your calcium level in the blood before I can say whether you should take or not calcium supplement. How do we know if cancer has spread to the bones? What are the signs of bone cancer? What are the signs to look for? There are some ways on how you can know the cancer that goes to the bone. In the easiest way, most oncologists, when they treat breast cancer, right, anything other than the very localized breast cancer, when they treat breast cancer, they will do a CT scan. Yeah. When they do a CT scan, they will see whether this cancer has spread to other organs or not, like to the liver, to the lungs, and maybe to the bones as well. Yeah. If let's say the liver and the lungs are clear, I'm sure like most people who had chemo will have a CT scan. If let's say the CT scan is perfectly normal, chances are the bones are also normal. Because we seldom ever see bone involvement without other organ involvement, without lymph node involvement, without lung or without liver involvement. So if let's say the CT scan is normal, chances are the bones are normal. If there is a sign of bone infection, right, then your doctor might do an extra scan called a bone scan or a technetium bone scan. This looks at the bone throughout your body because a CT scan just look from your neck to your pelvis to neck to your lower abdomen. But a technetium bone scan will look at the entire bone from your head to your toe. Yeah. So these are one of the options that they can do. Another ways they can do is that they can check your calcium level in the blood and decide on whether they need further investigation based on your calcium level. Yeah. Is it necessary to do bone tests every 2 to 3 years? Depending on the age, it may be necessary. If you are going into 70s, yeah, it could be necessary. Especially if the BMD is low. Yeah. Is vitamin D 1000 enough for my daily supplement? Yes. In most cases, it is enough. I'm not taking any calcium, just vitamin D. Again, in most cases, this is enough provided you take adequate calcium from your diet, means from milk and also from vegetables as well. Before chemotherapy, after looking at my CT scan, my breast surgeon briefly mentioned that my bone is older than my age. What could this mean? Okay. When your doctor says that you have bones which are older than your age, he or she is referring to this age. Yeah, this is the age. So this is 60 years old, this is 70 years old, and this is where a 60-year-old bone goes. This is where a 70-year-old bone goes. This is where an 80-year-old bone goes. Yeah. So these are the normal distribution of bone for people of that particular age. If let's say the doctor says you have bones that are older than your age, it might be, for example, if you are 70 years old, for example, but your bone is lower than a 70 years old punya point. So it means that you have more brittle bone than would be as compared to other people who are at the same age as you. This obviously will require, may or may not require treatment depending on how bad the BMD is lah. Yeah. Where did I left? Okay. A triple negative cancer is not hormone related, so it won't cause osteoporosis. It still can cause osteoporosis because cancer causes osteoporosis in many other ways, not just from the hormones. It can be because of the poor nutrition, from the catabolism, from the chemotherapy itself. So you can still get osteoporosis from this. I'm 63-year-old osteopenia before my breast cancer, so had radiotherapy and chemo, and 2 doses of Zometa. Had a hairline fracture during my treatment. Recently, 1.5 years ago, I fell, broke my thigh bone to head of femur, had surgery to add titanium plate. My bone has not grown as per normal, so it's taking a long time now, taking electronic. Is there anything I should take to expedite the growth? My family has osteopenia. This is a bit complicated question, I would say. Remember when I said that sometimes people who take bisphosphonate, they might get atypical fracture, right? So what Dayang Mariani described here sounds like an atypical fracture from bisphosphonate treatment. Management of atypical fracture like this is a bit not clearly, I would say not clearly well understood. Different people might treat it differently. My advice would be to talk to your doctor lah, because your doctor might have a certain idea in mind. They might have their own reason to give you the current treatment. Is there anything that you can do to expedite the bone growth? Unfortunately, not as far as I know. Yeah. My family has osteopenia. Yeah. So that could explain the risk factor lah. Can share how does vitamin D help cancer survivor? In general, it doesn't. Not that I know of lah. It does help with calcium absorption and bone health, but there are some studies that look at vitamin D and cancer, but in general, we don't really use vitamin D for cancer treatment purpose per se. Yeah, except for unless we have to treat their bones lah. How many types of bone scan? There are a lot of types of bone scan, but for our interest, we are talking about DEXA scan here, right? The one that I show you in the diagram. Usually, we are not encouraged to do scan tests yearly because your bone turnover is a very slow process. If you take it every year or so, you might not see a significant difference from last year and this year's scan. So, and that doesn't really give you a useful information. That's why we don't recommend yearly scan. If let's say your bone is declining or is deteriorating very fast, then some people might receive a yearly scan, but most people, they don't require a yearly scan. I have mets to sternum and doctor mentioned there may be possibility of a skull mets. Can you please show if there are any signs or symptoms to look out for? No, this can only be seen from a 1080 bone scan, which I mentioned earlier on. Yeah. How much is this DEXA scan? Okay, in my place is probably about less than 100. I'll probably say maybe about 30, but I might be wrong lah. Yeah. Is less than 100 lah. It's not that expensive actually for the DEXA scan. And you don't do, like I said, you don't do every year. Just do maybe once every few years only. If calcium level in our blood is high or sufficiently enough, is it okay to take extra vitamin D, calcium, or milk? Okay. When this person asks about calcium level in our blood is high, I would assume that this is not pathologically high lah. I would assume that this is not like abnormally high. So I would assume this is in the normal range. Yeah. So if your calcium is in the normal range, is it okay to take extra vitamin D? Yes, it is okay to take extra vitamin D, calcium, or from milk. But if let's say your calcium is abnormally high, so means it's more than 2.6 in the blood, right? Then you need to talk to your doctor. Can I do my squatting exercise even my kneecap is pain? It will get worse because I am doing my qigong. Well, like I said, any exercise is fine. So if squatting is difficult, I mean, you try to do whatever you can do lah. If you think you can do squatting, by all means go ahead because it's perfectly fine. Yeah. If bone is older than my age, then what should be done? Take vitamin D, calcium exercise as sufficient to help. In a way, yeah, it does. Vitamin D, calcium exercise, it does help. Is it sufficient or not? A bit hard to say lah because need more information. How much older than your age, and we also need to know your age also. But another thing that would be helpful would be to have a regular bone scan or regular BMD, yeah, to make sure that just to see the progression and to decide when you would require treatment with medication. Yep. Is there any other question?
Dr. Luqman?
Yes.
Hi, Dr. Luqman. I just want to check with you. Just now you mentioned your slides. I showed something about anti-seizure drugs, something like that.
Yep.
Okay, I'm actually on gabapentin for fibromyalgia. Okay, and I noticed ever since I've been taking tamoxifen, right, the pain is really bad. It's actually in my legs, around my knees. But the thing is, I'm also on piacidilline for osteoarthritis.
You're on what?
How do you pronounce this? Piacidilline for osteoarthritis for my knees.
Osteoarthritis.
For my knees, because I actually had a knee surgery when I was younger. So recently I've got this crickling sound in my knee. So the doctor actually gave me this. And because I'm on tamoxifen, I'm on this, and the pain for my fibromyalgia or what's really bad has this got anything to do with what I'm taking?
Gabapentin is not known to interfere with vitamin D.
No? What about
it's not tamoxifen either.
Sorry, could you repeat that? Sorry?
Gabapentin is not known to interfere with vitamin D or calcium. The ones that the slide was referring to are medications like valproic acid or epilim, phenytoin, carbamazepine. These are the common drugs that are used to treat epilepsy that can interfere with vitamin D metabolism. How it interferes with vitamin D metabolism is that these certain drugs they accelerate the enzyme that breaks down vitamin D. Gabapentin does not do that. So I would think that your gabapentin is quite safe to take, no problem.
Oh, okay. So I should just go on. What about the one that I was taking for I don't know how you pronounce it, piacidilline for osteoarthritis, for knee and for hip, because I've actually got it on my knee. So the doctor actually gave me that. He says a supplement, which is actually soya bean. Can I still go on?
Yeah, no problem. Shouldn't be a problem.
All right. Thank you so much.
Yep.
Thank you so much.
If someone gets bone cancer, does it mean constant daily pain or the pain will come and go? I cannot say because different people will get different types of bone involvement with their cancer. So some people may get pain, some people don't get pain, some people may just get high calcium. Different people will have different symptoms. How frequent test of vitamin D level needed? Usually it's just one time. And if it's not normal, we may repeat it. We may need to repeat after treatment. But if let's say that one time is already normal, then usually we don't need to repeat. If calcium is 300 milligram and also take colostrum that has calcium 1000 milligram, is that alright for men about 63 years old? Yep, that's fine. That's perfectly fine. What food to avoid with ER positive breast cancer? I am not an expert in this though. As far as I am not aware of, I think some of you might know better about this than me actually. I'm not aware of any food that people with cancer should not take, to be honest.
Basically, the advice we are given is a normal diet and stay within moderation and don't take anything in extremes. Basically, that's what it is. There's no specific food restriction or anything like that.
Sorry, Dr. Long, one last question. Miso and soya. I actually take soya quite a fair bit because I can't take milk anymore. So I also take miso sometimes because I like Japanese food. So what has that got to do? Does that help? What is it supposed to do for my bones? So I don't know whether I should be taking that.
Okay.
I am estrogen.
Soya has a chemical called phytoestrogen. This is a plant estrogen. Yeah. Phytoestrogen has been marketed a lot as a form of estrogen supplement. Truth is, in medical research, people have not found any effect or any evidence that phytoestrogen carries anywhere near the level of a normal human estrogen. So I would probably say, unless your oncologist or your dietitian says otherwise, I don't see any reason why people cannot take soya actually.
Okay.
Yeah. Of course, if you take loads and loads and loads of soya, you might end up with a lot of phytoestrogen lah. But like what Ranjit says, the key here is moderation. I don't think you should avoid from taking soya unless told otherwise.
Okay.
Same goes with any other estrogen food as well.
Okay. All right. Thank you. Thank you.
How does weight training help with bone strength? It doesn't actually. It doesn't help with bone strength. It helps with muscle strength. So like we mentioned earlier, you need to the exercise what it does is strengthens both bones and muscle. So this is where weight training helps lah. There's some research that milk cause breast cancer. Can we still take milk? I don't think this research carries some weight because it's not a widely known research. I don't think people have reproduced this. It's probably some statistical fluke. I would say yeah, can take milk, no problem.
All right, we come to the end of the session. Thank you so very much. Thanks. And everyone, have a good day. Dr. Luqman.
Thanks a lot, Ajit. Okay.
Okay, bye-bye.
Bye.